with some excellent references and resources that might be valuable to the attendees as well. Dr. Yilmaz has been an amazing teacher because his knowledge and the content expertise, absolutely, but the image selection's always great. And then the audience interaction and the different methods he has of interacting and engaging the audience have always been great. So we really welcome open engagement, questions, participation in any polls. I think it adds to the lectures, and we don't want anyone to feel intimidated. This is my 5th time around and I still get the hepatobiliary tumor questions wrong. So just make you do your best. And we're all still learning. So welcome everyone. It's really a pleasure to see additional attendance. And thank you very much to Ali and to Leah for organizing and helping to put this together once again.
Thank you very much, Dr. Zakos. It's a pleasure. And this talk was more than 2 hours. We summarized with Sam in the past, and this is going to be the shorter version, but if you have any questions, I'm happy to give you further details. So this is the most important slide of my talk. I wanted to summarize here the most common liver tumors that are seen in children. And this is actually this is not including all the tumors, but most of the tumors are included here. And I also included the non-neoplastic lesions for differential. These are the most common ones, but of course not limited. So these tumors are like benign, malignant. So how do we differentiate them? We have some important features. One of them is the size of the lesion. If the tumors are greater than 5 centimeters, they are more likely to be malignant. And we have also an helper alpha-fetoprotein, because in hepatoblastoma and HCC, there's increased alpha-fetoprotein, so they help us to differentiate. But the most important one is the age, as you can see here. Some tumors are most commonly seen in the younger ages. Some tumors are in the older ages. And these are very helpful. For example, here, this is the age distribution. Red ones are malignant. Yellow ones are benign, and blue ones are non-neoplastic lesions. As you can see, most of the tumors here are under 10. Like there's a predilection. So, for example, adenoma, FNH, AML, biliary cyst adenoma, epithelioid hemangioendothelioma are most commonly over 10. But infantile hemangioma, hepatoblastoma, neuroblastoma, metastatic neuroblastoma, malignant rhabdoid tumor, mesenchymal hamartoma, these are all under like younger ages. So this is very helpful, and we are going to use this for the differentiation. So I would like to start with a little bit of technique. The imaging modalities that we use for the assessment of pediatric liver tumors are ultrasound, contrast-enhanced ultrasound, CT, and MRI, basically. Ultrasound is initial imaging modality, good for screening, but suboptimal in obese patients and has low specificity. But the specificity increases with contrast use. And we recently started in our department, but we are not using it in the liver yet. But this is really good if there are a few lesions. If there are multiple lesions over 10, it will be difficult. And if the lesions are deeply located, deeper than 10 centimeters, it will be difficult. And contrast-enhanced ultrasound is good for the initial assessment, but not the best for staging or response treatment, and also approved by FDA. CT, we usually don't use CT, try not to use in children, but it's a must sometimes for the assessment before the surgery, because the vessels are better seen. And most of the time, for staging purposes, we scan the lungs with CT because MRI is not that sensitive yet. So while we are doing the chest, we include the abdomen as well. Dual energy CT is great. It reduces the artifacts, and the lesion detection is very good for dual energy. We are using it in our hospital, and there is this new emerging technology, photon counting detector CT, that the X-ray photons are directly recorded as electrical signals. So the dose is significantly reduced, and in the future we will be seeing more often use of photon counting detector CT in children. We usually try not to do multiphasic imaging for children when it comes to CT, because we are doubling, tripling the dose. But in these cases, especially in malignant tumors, we need to do multiphasic imaging. And this is the recommendation of the LIRADS working group. So we routinely get an arterial phase and a portal venous phase, including the chest for staging. And if there's a concern of HCC, we add an additional third phase between 3 to 5 minutes. MRI can be variable. The technique here is just a sample, and MRI requires sedation, and the lung lesions under 5 millimeter cannot be reliably assessed on the MRI. But MRI is definitely the best modality to assess these tumors. And according to the LIRADS working group recommendation, the contrast choice is hepatobiliary contrast. That's the first choice. So we should start, if there is a mass, or there's a concern of a mass, we should start with the hepatobiliary contrast, which I mean gadoxetate, Pirmovist or Eovist, or gadobenate, which is multi-Hens. So according to the age, I created some scenarios, 3 scenarios: a newborn, young child, and older child. I will review the imaging according to the age, starting with the newborn under 28 days. So these are the most common lesions that we can see: hemangiomas, congenital hemangioma, infantile hemangioma, mesenchymal hamartoma, infusate extravasation, and simple cyst. This is the review of hepatic hemangiomas. So if there's a single lesion, it's a congenital hepatic hemangioma. It's presumed to be a congenital hepatic hemangioma, because infantile hemangiomas are multiple. And when it is a congenital hepatic hemangioma in the liver, it is presumed to be a rich, rapidly involuting congenital hemangioma. Other types are not seen in the liver. And this is congenital one is present at birth. These infantile hemangiomas arises weeks to months after birth, and with the typical growth pattern. And they can be multifocal or diffuse. Diffuse form is the severe form of the multifocal, and there is no cutoff as size when it becomes a diffuse. But when it's very aggressive like this, we are calling it a diffuse. And clinically, this congenital hemangioma is the most benign one, and it resolves within months, 12 to 14 months. It is called rapidly because it's compared to infantile hemangiomas, which resolve up to 5 years. So it is rapid compared to 5 years. 1 year is still rapid. And these are GLUT1 negative, and beta blockers are ineffective in this group. Beta blockers are effective in the infantile hemangioma group. One important thing in imaging is you see a spherical enhancing solitary lesion and very prominent vessels. These vessels can be seen around the mass too. It doesn't have to be only in the lesion, and there may be intratumoral shunts. And so this is very typical. In a congenital portal shunt, we don't see a solid enhancing mass like this. And these are typical. There may be associated cutaneous lesions. In the congenital ones are not much. Clinically, there may be hypothyroidism, cardiac failure, very mild in this group and more severe in this group. We will discuss in detail later. Here is a typical example of a congenital hemangioma. It's a ridge. The difference is centrally they may have a large non-enhancing component calcification like this. And it's very vascular, as you can see. There are very prominent vessels around it, sometimes shunting in the lesion. And it's T2 hyperintense, more heterogeneous compared to the infantile hemangiomas. And this central non-enhancing component is very remarkable. And as you can see, on the delayed phases, it keeps enhancing. And if you're wondering what happened to this lesion was detected at the 4 weeks of age. So we don't know if it was congenital initially, but because it was a single lesion, we made the diagnosis. And it decreased in size over months and then disappeared on the 20th month of follow-up. This is the typical, and the beta blockers are not effective. So we just wait. Another example, there is a large calcification. This is a difference between the infantile hemangiomas. We don't see calcification in the infantile hemangiomas. And here you can see the vessels around the lesion. And you may think that this could be a vascular malformation, but it's not. Then on the MRI, we see this enhancing mass, and you can see these very prominent vessels around the lesion, and it keeps enhancing. The mass keeps enhancing. It's only one lesion in the liver, not multiple. Here is an infantile hemangioma. It's multifocal. So there is a single large lesion, but there are also multiple lesions scattered throughout the liver, and prominent vessels in the lesion on T2, and it keeps enhancing, and there's a large non-enhancing component initially, but it disappears on the 5th minute. And this is a very typical enhancement. It's similar to the congenital hemangioma, but the number of the lesions are different. And we never see restricted diffusion in hemangiomas, although they appear bright on DWI. This is secondary to T2 shine through effect. On the ADC, we never see a true restricted diffusion. This is a very nice example for the growth pattern of hemangiomas. They show a proliferative pattern up to 6 months, then they stabilize, then they start to involute around 10 months, and then involute. And after, at this age, it keeps involuting, but very slowly after this. The hepatic hemangiomas are counterparts of the cutaneous hemangiomas. So they are histopathologically same lesions, and they show the same growth pattern. So we expect to see an hemangioma like this. As you can easily say, if you see a lesion that is arising at the age of 6 months, it cannot be an hemangioma. If you see a lesion that occurs after this age, it cannot be an hemangioma, but we are going to discuss the adult type hemangiomas later on. So if you're wondering what happened to that large lesion, on the follow-up, it showed the typical growth pattern, initially increased in size, at 4 months old started to shrink, and over 31 months, it completely disappeared. This is a little bit faster, but because we are using beta blockers, it makes the involution faster. And there's an important point. Infantile hemangiomas can appear hyperechoic or hypoechoic. They are variable. Adult type hemangiomas are always hyperechoic. That's the difference. And here is a case that I borrowed from my friend, Dr. Berna Oğuz from Hacettepe University. We are seeing these multiple lesions, very large in size and numerous, scattered through the entire liver, and the child has some symptoms, heart failure symptoms. These lesions are very vascular, and with beta blocker treatment, propranolol treatment, the complete resolution of the lesions. This is very typical. So there is a confusion of terminology for the hemangiomas. I'm using the term infantile hemangioma, most updated one, but in the past they were using infantile hemangioendothelioma or capillary hemangioma. This was the pathological definition. But currently we are using infantile hemangioma instead. And there is this hemangioma used in the older children and adults, very common liver lesion. But these are actually venous malformations or cavernous hemangioma in the old pathological terminology. Or currently I'm telling them adult type cavernous hemangioma. So and there is also this epithelioid hemangioendothelioma, which is a very rare tumor. It is benign, but it's a borderline tumor. It has malignant potential, but it's benign, and it's seen in older children. And this is also different. So we should be careful when using the term hemangioma. We should be more specific if it's infantile, if it's congenital, if it is epithelioid, if it's adult type, because adult types are venous malformations. And this is an adult type cavernous hemangioma. We can see them in older children as well. They are always hyperechoic on the ultrasound. You never see vascularity on Doppler, but we commonly see vascularity in the proliferating phase in an infantile hemangioma. That's the difference. And on the T2, these hemangiomas are very bright and close to the signal intensity of the gallbladder. But infantile hemangiomas are not that bright. They are T2 hyperintense, but not as bright. So these are very bright because they are venous malformations. And then they enhance from the periphery, interrupted nodular enhancement, and they show progressive fill-in of the lesion on the delayed phases. This is typical, and this enhancement pattern is somewhat similar to infantile hemangiomas, but infantile hemangiomas don't show this interrupted nodular. It's more like a ring enhancement, as you can see here. So I summarized here. This is the congenital hemangioma, infantile hemangioma. The enhancement pattern is more like a ring enhancement. But adult type cavernous hemangiomas are peripheric nodular interrupted enhancement. And these are diagnostic. You can make the diagnosis by seeing this feature without the need for biopsy. And also in these lesions, when combined with the growth pattern and the imaging features, you can make the diagnosis without the need for pathology. And epithelioid endothelioma, also seen in older children, very rare, and they may show the similar pattern. And in this group, you will have to do a biopsy. And after hemangiomas, I am moving to the mesenchymal hematoma. These are these group of tumors are diagnosed by age because they occur under 2, mostly in the infant, can be at birth or very early ages, and mostly cystic. So, and we can see the Swiss cheese pattern. The solid portions may enhance and may mimic this appearance. They are really big tumors and they may mimic malignant tumors. Here is 2 different examples. They are benign tumors and the prognosis is usually good after resection. And after this one, there are 2 mimickers, simple cyst and infusate extravasation. Here, infusate extravasation, you can also call it TPNoma because this is related to the umbilical venous catheters that are very commonly used in the NICU units. And when they're in low position or when they're in the portal system, the TPN or the medication that are infused through the catheter goes into the liver instead of the systemic circulation. And most commonly, that's the segment 4, medial segment of the left lobe. And the appearance vary depending on the content of the infusate. we can sometimes see calcification like this. We see vascularity because of the intervening hepatic vessels. And when you do MRI, you don't see much, as we didn't in this case. And they can mimic tumors. And sometimes they resolve within weeks. And I saw a case which stayed almost for 2 years. And there are also associated tiny echogenic foci scattered in the liver. It may be on the right lobe, left lobe, depending on the location of the catheter. And there is usually associated thrombosis of the left portal vein. And simple cysts, when we say simple hepatic cysts, we actually consider congenital cyst, biliary hamartomas, Caroli disease, polycystic liver disease. They are rare. And I'm showing you 3 different examples. One is an incidental cyst in the newborn. One is a 12-year-old. This is the lesion. This is the gallbladder, and there's some debris in it on the ultrasound. And another one, a simple hepatic cyst. So this cannot be a tumor. So what is the concern? The worst case scenario is a biliary cystadenoma. This cannot be one of those other tumors. But biliary cystadenoma is the worst case scenario. So how do we differentiate a biliary cystadenoma? They are so rare. And when there is a thick wall, solid mural nodule, mural or septal enhancement, if there are cysts less than 3, if there's upstream dilatation of the biliary tracts, if there are more than 2 septations, if there is debris, calcification or fluid level, it's more suggestive of a biliary cystadenoma. Here you see a 15-year-old female with biliary cystadenoma that I brought from my friend, Dr. Nursun Özcan. And this was histopathologically proven biliary cystadenoma, but most of the time the diagnosis is difficult. And after the first scenario, I'm skipping to the second scenario, a young child under 10 years with liver mass. And these are the most common tumors. The others can also be seen, so I made them like yellowish, but we are going to focus on this group. So we are starting the malignant group. As you can see, it is not possible to differentiate between these malignant groups because they present with a large, heterogeneous, ugly-looking mass, and they usually require a biopsy. Hepatoblastomas can be diagnosed with increased alpha-fetoprotein. For example, in this child, there is increased alpha-fetoprotein, a large mass in the liver, very heterogeneous. There may be some cystic lesions, very necrosis, central necrosis, hemorrhage, calcification, typical, as you can see here. There is restricted diffusion because it's malignant. Very heterogeneous, some calcification or hemorrhage here. And there are areas that do not enhance due to necrosis. And so in this child, the child is 7 months old, but under 1 year, the alpha-fetoprotein levels are normally high and they show a significant variation. So it is not reliable to assess the alpha-fetoprotein for the diagnosis of hepatoblastoma, but it's important to see if the alpha-fetoprotein levels are increasing and not decreasing. So under 1 year. So we should also consider that. And another example, very large tumor, very heterogeneous, ugly looking. In the lesion, there's T1 hyperintense areas, calcification or hemorrhage. Here you can see on the T2 areas of necrosis that do not enhance exophytic mass. They can be quite large, multifocal or solitary lesion, and they may present with metastatic disease. This child also had the increased alpha-fetoprotein. An interesting thing, this is a child, 4-year-old male, but presenting with hyperrealization and precocious puberty. And this is the bone age. So initially, we saw the X-ray, and the bone age was 8 years, very advanced. And then we started looking for a mass, and there was this mass. Initially, we thought this was an adrenal mass, but adrenal gland was normal. So it's a exophytic hepatic mass arising from the left lobe of the liver. There are internal calcifications, very ugly necrotic mass. So how is that possible? Because increased alpha fetoprotein and beta HCG causes increased testosterone. So increased testosterone may present with, may cause this, and the patients may present with precocious puberty. In 18% of the cases, there is increased testosterone. And so what do we do in the hepatoblastoma treatment? So very basically, roughly, the COG approach in the North America and COPEL is the Europe approach. Initial surgery is done when a complete resection can be done with a simple negative margin hemihepatectomy for patients with pretext 1 and 2 tumors. I will explain what pretext 1 and 2 is. So if the tumor is resectable, it's resected. In COPEL, there is preoperative chemotherapy, which is called neoadjuvant therapy for every patient, and then followed by a surgical resection and 2 postoperative cycles of chemotherapy. And then if the tumor is advanced, liver transplantation is considered for the treatment. And this pretext staging is based on the Quino segmentation. And the guy is French, so it's called Quino. And this is based on the segmentation. There is this left lobe, left lateral section, left medial section, right anterior section, and right posterior section. And the landmarks are middle hepatic vein and gallbladder, hepatic fissure, and the left portal vein, the umbilical portion of the left portal vein, not the left hepatic vein. So we should know that. And based on this pretext classification, you can see all the possibilities here. The important thing is when a lesion is central, the stage can be higher. For example, in this group, there's only one lesion involving the central section, and it is still pretext 2 because the surgeons prefer a left hepatectomy, so they resect 2 sections. Also here too, but when they're peripheral, it's only one. Here also as example, there are 2 sections involved, but here, for example, 2 sections involved, but the stage is 3 because the surgeons cannot leave this section. And there are also annotation factors, and this is very detailed and not an easy system. For imaging, this is a pretext 3 tumor, for example, here extending to the anterior, right anterior section as well. Just to show you, this is the hepatoblastoma and this is the hemangioma, and they are different. Hepatoblastoma appears very ugly, heterogeneous. Hemangioma appears homogeneous. And here we started the chemotherapy, the tumor shrank, hemangioma stayed, hemangioma didn't change, and it was resected. So we confirmed that this was an hemangioma, infantile hemangioma, and this was an hepatoblastoma. And hemangioma, as you can see, peripheral enhancement and keeps enhancing on the delayed phases, but hepatoblastoma is never like that. So for this tumor, the initial diagnosis was pretext 3 because it was extending to the right lobe. Then after chemotherapy, the stage was stage 3, then decreased to 2. Then we are calling it post-text because we started the chemotherapy. So this was pretext 2, then it is amenable to resect, and the surgery was done at this stage. So the surgeons preferred the left hepatectomy, and then the patient is doing well afterwards. And the other malignant tumors, the imaging features are usually not very helpful. For example, malignant rhabdoid tumor. we see an ugly mass with metastatic disease, multifocal, there's a very large predominant one, and multiple lesions in the lung as well, and also on the ultrasound. This is 6 months old, a little bit early for hepatoblastoma, but it can also be an hepatoblastoma. But on the histopathology, we made the diagnosis. Angiosarcoma is very rare, and this is the malignant version of an infantile hemangioma. So extremely rare, but it can happen. And as you can see here, it's a very ugly looking large size mass with vascularity, with necrosis. And the diagnostic feature here is the blood lake, blood pool that you can see on the CT and also on the DSA study. This is important because these blood lakes can rupture during biopsy, and they may be lethal. So we should be aware of that. Biliary rhabdomyosarcoma, they may follow the course of the biliary tract, so it may help, but not all the time. They may be very focal and very large tumors, and they usually require a biopsy. They're very rare. For example, this child has it had ulcerative colitis and primary sclerosing cholangitis that may help for the diagnosis, and had this tumor that followed the biliary tract. And here there is restricted diffusion in the tumor, so we knew that it was malignant, and the biopsy confirmed the diagnosis. Metastatic disease, we should consider, for especially the neuroblastoma metastases may be undercalled as hemangioma, misdiagnosed actually. For example, 3-month-old, if you see multiple lesions like this, don't call this as hemangioma. There is always check for the adrenal glands, because they may look like hemangiomas, and these children may have a wrong diagnosis of multiple hemangioma. For the third scenario, the last scenario, an older child over 10 years old with a liver mass. So these are the most common options that we are seeing. And I will start with HCC. And typically there is increased alpha-fetoprotein, and the children are usually over 10 years. And not by imaging, but with these two features, we can make the diagnosis. On the imaging, in the adult HCC, the imaging features are typical. Enhances during the arterial phase, portal venous washout, then rim enhancement, capsular enhancement. But in children, we don't usually see these features. There is usually a very large, ugly looking mass with some metastatic disease, and on the MRI, same thing. So usually diagnosed with increased alpha-fetoprotein and the age. There is a subtype of HCC called fibrolamellar type. And this is actually quite different than the HCC, because the alpha-fetoprotein levels are normal. In HCC is usually there is an underlying liver disease, but in this group there is no underlying liver disease. And the imaging features may overlap. We see, and the overlap may be overlapping with an FNH as well, because of central scarring and lobulated contours. But what we are seeing is a large heterogeneous mass with some necrosis, and they may keep enhancing during the late phase. That's why they may be diagnosed as FNH at times. Many authors consider this as a different type of tumor rather than a subtype of HCC. And histopathologically, hepatoblastoma and HCC are close tumors, and they may have overlapping features. And there's a group called HCC-like hepatoblastoma, and also called transitional liver cell tumors. As in this case, this patient had chronic liver disease due to hemochromatosis, and this tumor was resected. The patient had transplants. That's why we can see the entire liver here. And this is a very non-specific, ugly-looking mass, on enhancing mass and showing restricted diffusion. and the biopsy confirmed the diagnosis. This is very rare. And after this one, there are benign tumors in the older ages. FNH is the most common. These are not true tumors. They are actually response of normal hepatocytes secondary to a vascular malformation or AVM, as you can see here. This is a feeding artery. So there is usually a central feeding artery and the tumor around it. Here is an example. It's very vascular. There's a central feeding artery. The vascularity may look like a tree, like dendritic pattern, or a spoke wheel pattern can be seen. On the MRI, the lesions can be isointense with the liver parenchyma. Central scar is typical T1 hypointense scar here, and the scar enhances with contrast. In this case, we injected gadoxetate, and the scar started to enhance on the 15 minutes. And the typical pattern is very vascular during the arterial phase, and it keeps enhancing on the delayed phases. And we can make the diagnosis with persistent enhancement during the 15-minute or 20-minute with gadoxetate. Here, it is enhancing because compared to the normal liver, it should normally be darker, but it's not. So it's isointense, so it is enhancing. Another example, on the ultrasound, we can see the lesion hypoechoic, but there is central feeding artery. And on the MRI, the central scar is seen, T1 hypointense and T2 hyperintense scar. And this scar is enhancing, both also with the gadobotrol, the extracellular, not hepatocyte-specific contrast agent. Same thing. And also these FNH can be difficult to visualize. For example, this 14-year-old male had a trauma and had the ultrasound, and incidentally, a lesion was detected in the liver with central feeding artery. The contours are quite difficult to differentiate from the normal liver parenchyma. That's why I called it a stealth tumor. Even on the MRI, it is very difficult to see them. For example, same lesion, on the T2, you don't see it. T1, in phase, out phase, you don't see it. On the diffusion, no. Pre-contrast, no. And you just see it on the arterial phase. This is very typical enhancement pattern. And then on the portal venous phase and other phases, you don't see it. I call it stealth tumor. So how do we know this is FNH? Because we also did a gadoxetate study, and we showed the enhancement during the 20 minutes. So this was an FNH. So you don't need to do a biopsy in this group of patients. A study with gadoxetate is enough to confirm. And the enhancement pattern on the 20th minute can be variable, ring pattern or homogeneously enhancing, or with the scar. And these are just different enhancement patterns. There was a case with medulloblastoma. It's a very malignant brain tumor, but it's extremely rare to do extracranial metastatic disease. But patient presented with multiple liver lesions 3 years after treatment. And here they look like metastatic disease because they have this hypoechoic rim. And on the MRI, we showed the same lesions. And here we can see multiple lesions. They don't really show restricted diffusion, but they keep enhancing on the delayed phases with extracellular contrast. So that's so helpful for the diagnosis of FNH. So we made the diagnosis of FNH, but because we didn't use gadoxetate, we were not quite sure. So we also confirmed this case with gadoxetate rather than doing a biopsy. And on the delayed phase, we see the ring enhancement. So we confirmed the diagnosis of FNH. But the patient presented with multiple lesions on the follow-up. So somehow the surgeons wanted the MRI follow-up. And on the follow-up, we saw some additional lesions here, for example. This is baseline. We saw this additional lesion. This lesion is becoming larger. For example, this lesion is getting larger. This lesion is getting larger. So, and they asked us, hey, you told us this was an FNH, but on the follow-up, there are new lesions and the previous lesions are increasing in size. Are they metastatic? No, because FNH can do this, and it was shown with research studies that they can increase in size, and you can see additional lesions on the follow-up. Adenomas are a very distinct entity, and they are rare in children. We rarely see them, and when we see them, we make the diagnosis by the underlying etiology, like glycogen storage disease, galactosemia, mucopolysaccharidosis type 1, or familial adenomatosis polyposis syndrome, or Fanconi anemia, or anabolic or oral contraceptive drugs. On the imaging, they are hypervascular, single or multiple lesions, as you can see here. Arterial enhancement is typical. They don't keep enhancing during the delayed phases usually. And there may be fat or intravascular fat. And the importance is for malignant transformation or hemorrhage. But because of the very low number of the cases, we don't have experience. And these tumors are very important, especially in the adults, because just like medulloblastomas, you can make the molecular subtype diagnosis by using the imaging without a need for biopsy. By looking at the imaging features, you can tell the referring physician that this could be a hepatocyte nuclear factor 1 or this beta-catenin mutated or inflammatory group. These are the molecular subtypes, and you can make the diagnosis by imaging. And epithelioid hemangioendothelioma, very rare tumors, has benign tumors, but borderline malignant potential 5%. So they need screening, because when you see them, they don't resolve by themselves, and there is a potential malignancy. So you need to follow them by ultrasound or by MRI. And here's an example, 17-year-old, asymptomatic, but multiple lesions. And the enhancement pattern is similar to the hemangiomas. They may keep enhancing on the delayed phases. They are T1 hypointense, T2 hyperintense. And typically on the Doppler, they are vascular. There is a vascular pedicle portal vein or hepatic vein, and there is this lesion. It was described as the lollipop sign. And this is a typical feature, and retraction of the lesion is retraction of the liver capsule is typical. But they may also present with a single large mass with calcification, as you can see here, and you can see the enhancement pattern, peripheral enhancement, continuous peripheral enhancement. And so after this one, I'm going to skip to the focal fat infiltration. We don't have enough time to discuss everything, but this is important. This is the final entity. Focal fat infiltration, the important point is they're extremely rare under 5. So if you see focal fat infiltration under 5, you should probably not make the diagnosis and further investigate these lesions. Although they are focal fat infiltration, they may be more diffuse, as you can see here, or focal. They may be intraparenchymal. They may be adjacent to the falciform ligament, one of the most common locations. They may be adjacent to the gallbladder and anterior to the portal vein. Here is the same lesion on the Doppler. This is very helpful. If they have a vessel, for hepatic vein, for example, traversing through the lesion, you can see the vessel very nicely. There is no mass effect on the vessel. There is no thrombosis, and you can make the diagnosis by using that. And here you can see the same. The hepatic vein is traversing the lesion, and there is no mass effect on it. It's patent. You will never see this in a hepatoblastoma or in a malignant tumor. There will be at least some mass effect on this here too. So I wanted to summarize all these tumors and some important points. Reliable diagnosis based on imaging can be made in only a few entities, such as hemangioma and FNH, and biopsy should be avoided for these lesions. Infantile hepatic hemangiomas are typically multiple lesions and associated with cutaneous hemangiomas, usually. Congenital hemangiomas are typically single lesions and not associated with cutaneous hemangiomas. Adult type hemangiomas are different entities than pediatric hemangiomas and are actually venous malformations. However, they may have overlapping imaging features. And FNH may occur years after completion of the chemotherapy, radiation therapy, or bone marrow transplantation for other malignancy. And thank you for listening. I will stop here and I will take questions if you have any.